Hello, my name is Dr. Motti Haimi. I'm a physician and a medical director and lecturer in living in Israel. I wanted to talk about our study recently published in JMIR. It's called the Telehealth Usage Disparities in Israel in light of the COVID-19 pandemic, retrospective cohort study of intersectional socio-demographic patterns and health equity implications. And as you know, the post-COVID-19 environment catalyzed a dramatic acceleration in telemedicine integration, positioning it as a fundamental modality for healthcare delivery. Our objective was to critically evaluate the penetration and utilization patterns of telehealth services within our universal health system to identify potential health equity deficits. We conducted a retrospective cohort analysis using health and administrative data from electronic database of Clalit Health Services, Sharon Shomron District in Israel. The study population comprised almost 500,000 adult members, with continuous enrollment from March 2019 to February 2022. And we analyzed telehealth usage across 3 periods that were pre-COVID-19, COVID-19, and the post-COVID-19 period. Telehealth services included telephone consultations, video consultations, and Tyto-Care remote diagnosis device usage. Primary outcomes were telehealth usage rates and after-hours usage patterns. We use descriptive statistics, temporal trend analysis, and multivariable logistic regressions. The data confirmed that there was a significant increase in service penetration, with unique member telehealth utilization rates more than doubling across the pre- and post-pandemic study periods. This functional shift from telehealth as an alternative to an integrated component is really evident. However, our analysis reveals a non-uniform distribution of these technological advancements across the patient population. We identified pronounced statistically significant intersectional disparities. Utilization rates were inversely correlated with several key social and demographic determinants of health. For example, socioeconomic status. Patients in the highest socioeconomic status level demonstrated utilization rates nearly 4 times greater than those in the lowest socioeconomic status category. The second thing is the age cohort analysis. Utilization among younger adults, 25 to 35 years, was 3-fold higher when compared to the geriatric population, 70 years and higher. And also cultural and geographic disparities. We observed that up to a 10-fold variation in utilization between distinct ethno-cultural groups, indicative of significant barriers related to health literacy and digital access. The core implication of these findings is that absent targeted intervention, the rapid expansion of digital health infrastructure risks exacerbating existing health inequities. Our data suggests that a differential uptake that favors already privileged groups is potentially leading to a fragmentation of care and widening the outcome gap for vulnerable population. This structural inequity demands immediate mitigation. The mandate is clear. We must shift from simply enabling telehealth to ensuring equitable digital integration. This requires a multi-pronged systemic approach, including the development and deployment of resources for digital health literacy programs, cultural competency training for providers utilizing telemedicine, and strategic investment to overcome technological access barriers for marginalized groups. Our commitment must be to leverage digital innovation as a tool for achieving universal, high quality, and truly equitable patient care. Thank you very much, and I hope that you will read this article soon, and thank you all.